welcome. Tonight, we have a bit of a shortened program just because Dr. Klinge is actually on call later and has to jump off. But I think with that, we're going to get started right away. I don't know if you want to quickly introduce yourself and let everyone know about yourself.
Yeah, all right. Yeah, so my name is Dr. Petra Klinge. I work at Rhode Island Hospital, and I'm a pediatric and an adult neurosurgeon taking care of congenital diseases of the brain and spine. As many of you know, my main focus is tethered cord syndrome in the occult and other settings, but also I'm the director of the Center for the Cerebrospinal Fluid Disorders, and happy to also answer any questions about the spinal fluids in the brain and the spine. All right.
Excellent. Okay, so I think with that, I'm probably going to just jump right into the questions because we actually got a lot.
Yeah, I'm sorry. I had to take call, and we have
No.
to consolidate questions.
No worries.
Do a follow up on this if needed.
I tried to condense a lot of the questions so that maybe we can touch on everyone's point a little bit more quickly.
Sure.
So the first question really has to do with the phylum Terminale. So I guess first of all, what is it? And what's quote unquote wrong with it in tethered cord patients?
Well, so what is it? I started to say that this is our little embryonic tail. So as an embryo, we have a tail where that tail is consisted of bone and spinal cord and helps to develop our legs and probably also like the lower organs. And then once this is developed, the tail moves back into the spinal canal. And the embryonic spinal cord that was in the tail is now our phylum. So it's basically embryonic spinal cord. This process is very delicate, and a lot of things cannot go the way they're supposed to. So sometimes that tail stays too thick, too short, and there can still be a lot of embryonic material in there, and then it starts to like act as a like a rubber band that can pull on the spinal cord, affect the nerves. So basically, it's embryonic spinal cord, which can which can cause a lot of trouble to the adult spinal cord if it hasn't formed the way it should. I hope that makes sense.
Yes.
But that is also the problem is with that. That's why it sometimes cannot be seen on the MRI. So there's like these occult situations are the ones where the tail is still abnormal, but you don't really see the obvious on the MRI. And that substantiates the diagnosis of occult tethered cord, where you have the symptoms, but the MRI is not really telling and not diagnostic.
Okay. A couple of people actually asked about like histopathology. So do you know what proportion of patients with no MRI findings will have an abnormal biopsy in the phylum after surgery?
Yeah, I'd like to just get away from the term biopsy because it's not really a biopsy. Usually, a lot of surgeons would like resect a part of the phylum in order to prove that that's the phylum, and also to provide like a maximum resection of the pathology. And so it's like just a pathological specimen. So let's not call it a biopsy, because biopsy is more like an indicator of something that is providing some prognosis. But we're not talking about prognosis here. We're just talking about like understanding what's wrong. So the resection of the phylum often shows abnormal cells, like embryonic cells, as I said, as a sign of like residual embryonic spinal cord in that phylum, which can make it too tight. Then often in the pathology, we see like inflammatory cells, or also with electron microscopy, we see the abnormal collagen, which is more often seen in people with hypermobile EDS versus people with no known diagnosis of EDS. So abnormal collagen, inflammation, and cell leftovers from the embryonic times makes it a bad phylum. And so in people with tethered cord syndrome, it's the chances that we find abnormal cells in the phylum or abnormal structure in the phylum are more than 90%.
Wow.
So we're trying now to, our research is now that we are trying to correlate the abnormal phylum findings with the symptoms to see, you know, like to get a better clinical diagnostic marker, because at the end you don't want to find out after the phylum resection has been done. You want to have like clinical diagnostic markers.
Right. That kind of leads to the next question. Is there right now any correlation between the findings of the under the electron microscopy or otherwise and symptoms in these patients?
We're looking at it right now. We don't have any. So that we are working at looking at the clinical correlation and the pathological findings. So far, what we can say that it looks like in people with hypermobile EDS, there is a higher prevalence of abnormal collagen, which speaks to the syndromic nature of a phylum terminale pathology. But we are just now correlating it with the symptoms, and hopefully in a few months we will be able to also tell a little bit about symptomatology and abnormal phylum pathology.
Excellent. What do you, I guess this is like a hypothesis sort of question. What do you think might unify patients that have a quote tight phylum and those who have an obvious visible tether? So what do you think is the connection between tethered cord syndrome confirmed on an MRI and occult tethered cord syndrome? If you had to guess.
Yeah, so, well, you mean like in terms of symptoms?
Yeah, well, since the symptoms are similar, what do you think they have in common underlying, I guess?
Oh, I mean, so what is really not encouraging, but the syndrome itself, qualified by bladder abnormalities, leg weakness or leg symptoms, and other neurological findings in the legs and back pain, those are pretty much equal between those with radiographic positive tethered cord versus radiographic, negative tethered cord. So there isn't really like a, so when looking at the symptomatology between people with known tethered cord on the MRI and not seen tethered cord in the MRI, there isn't a big difference. So that supports the syndrome and supports the clinical picture that we should appreciate and which substantiates the diagnosis and ultimately justifies surgical intervention. So there is not a significant difference in the symptoms.
Okay. I'm going to move on to possible associations and other disorders. We actually got a question in the chat that I want to address first. Is there any evidence of tethered cord syndrome and maybe chronic fatigue syndrome? I know there's been some overlap with that with like EDS and similar conditions, but anything known at this point?
No.
Okay.
No. The one thing that I like to say is certainly chronic pain can cause chronic fatigue. And just today I had a few people that I saw which so if you have like weakness in the legs, and if the legs are in pain and ache, that certainly affects your entire body. So neurological symptoms have an impact on the overall body function and body capacity. So that might occur as a chronic fatigue syndrome, but in fact it's less like a weakness of the extremities in the presence of a neurological problem in the spine. But there isn't really like a good, correlate, like not a scientific evidence whether chronic fatigue syndrome is caused or encouraged by tethered cord, but it might also be that from abnormal fluid dynamics that are associated with tethered cord syndrome, that this is part of, a fatigue syndrome caused by that.
Yeah. Speaking of fluid. um,
Mhm.
there is a question about the link between tethered cord syndrome and CSF leak or intracranial hypertension. And kind of okay, so I'll say, do they share the same root cause or are they completely separate?
Like hypertension and tethered cord, is that what I'm getting?
Yes, yes.
Yeah. So this is pure research,
Right.
but I was like, I try to, so I hope I make the point. So it is, so when you scrutinize the literature that has been published about the phylum and the conus and the transition of the phylum and the conus, you it's been described that at the conus or that the conus phylum transition, there are pressure sensors, like sensors that modulate the intracranial pressure. We have those sensors in our fourth ventricle, in our brain ventricles, but it's been shown that it's also at the bottom of the spine. So this was shown in like cadaver studies where they found fibers that control the intracranial pressure at the bottom of the spinal cord, at the conus, and the phylum transition were similar to those that control the intracranial pressure. So yes, based on that, you could say that the intracranial pressure is also controlled at the bottom of the spinal cord. And if you have an abnormal phylum that's pulling, you might say that there also might be like a misregulation of the intracranial pressure. I see a lot of improvement in headaches after tethered cord release, probably in more than 70% of people. And sometimes that is even the first symptom that improves. So we have to assume that the base of the spinal cord is also part of controlling the intracranial pressure.
Okay.
That's backed up by anatomical studies.
Right. So sort of to what you just said, there was a question sort of about, could tethered cord maybe play a role in pulling the cerebellar tonsils kind of down and creating, quote unquote, a Chiari malformation? Is that something that you've seen, or?
Well, I would not say it's creating a Chiari malformation. We don't know that. And a lot of other neurosurgeons would be are very guarded to support that. And let's say the coexistence of Chiari and tethered cord might aggravate, like a Chiari that might not be symptomatic otherwise. So we always have to assume that with the Chiari, there might be the coexistence of tethered cord, and if the tethered cord is the major pathological element in a person's condition, it might certainly, with causing intracranial pressure dysregulation and causing abnormal locomotion of the spinal cord at the base of the skull, certainly also makes the Chiari worse. So basically, how I see it now, in my opinion, based on our research, is that combination of Chiari and tethered cord, not even looking at like the tethered cord causes the Chiari, is just like a vicious cycle where the Chiari is disturbed more than it would without tethered cord. Does that make sense?
Yes. So say in a patient that might have really pronounced tethered cord symptoms, and they also have either low-lying tonsils or a Chiari, whether or not that's called a Chiari on their MRI or by their doctor, have you noticed that in those patients, if they get a tethered cord surgery, do their Chiari symptoms get better? Or I know you mentioned headaches before, but there are others as well.
Oh yes, I see that a lot. I mean, not saying, I don't want to over deliver here. I should be honest. It's not always helping it, and sometimes those symptoms get worse. But in my personal experience, there's like more than 50% of people that say that like sometimes the ears being underwater, which I more attribute to Chiari, they're getting better. Vision, floaters in the eyes, also the suboccipital headaches. So just today there was a lady that described that her whooshing pain in the base of her skull has gotten better. Yes, the Chiari symptoms do get better, and that speaks to the fact that you probably, by releasing the cord, contribute to a better, like spinal fluid circulation and pressure regulation at the base of the skull. As I said, I'm very intrigued by the fact that it's been shown in anatomical studies that the pressure sensors of the spinal fluid are also at the phylum cord transition, and we're looking at it right now. But that must be that we have not only like a cranial regulation of pressure, but also a spinal regulation of pressure, and it's just right where the phylum is.
Okay. There was a question about whether postoperative adhesions may cause tethering of the cord. Is that something that you've seen or that's in the literature at all?
Yeah.
Okay.
Literature, yeah, it's in the literature, but so what's in the literature is that certainly every intervention in the spinal canal, particularly at the level of the cauda equina, that's the nerve that came out of the cord, so when you resect the phylum, you are within, like all these little nerve rootlets. So the main sequelae or risk of the surgery, unfortunately, is that where you resect the phylum and where you open and close the dura, you can cause a scar, an arachnoid scar. That is a scar within the spinal sac, where the nerves can retether at the site of your incision or your opening of the dura. Thanks God, it's not a high risk, but it can happen, and that's why I usually, you should do an MRI after the surgery, like at 6 months mark, to just kind of see how everything has healed and to exclude an arachnoiditis. So basically, arachnoid adhesions can be a source of retethering. It's not the phylum, but it's the nerves, and it is as much of a tethering as the phylum has provided.
In those cases, is that something that would need to be surgically taken care of, or is there?
It can. Okay. Yes, it can. So you can certainly monitor, as you always have the opportunity to monitor with the cord. But usually, if there's again like the same symptoms as with the tethered cord prior to the phylum resection and it's progressing, it's a reasonable option to go back in and release those nerves safely. Certainly, you have to make sure that the MRI doesn't show like a significant scar, which probably is a little bit of a concern to just make the scar worse. But if it's just a minute tethering of the cauda nerves, it's reasonable to offer a second surgery, and it can alleviate the symptoms, and it might not necessarily occur again. But you have to be very honest to the person and tell it might just be the nature of the problem that you develop a scar. Why that is, why some people have that risk of developing the scar and why others don't have it, we don't know yet. I always say that it's very important to have the tethered cord surgery done without any like bleeding. You want to prevent a pseudomeningocele, and I have mentioned that in some of my webinars, that risks of, you should prevent spinal fluid leakage and bleeding during the surgery, because these are all inflammatory processes that can encourage retethering.
Mm-hmm. So a handful of the doctors on our board and who have done these things have said, say you have instability, Chiari, and tethered cord. The surgery is generally, I think it's a thing in neurosurgery that you do surgery from the top down. Is there a reason for that? And is it possible to have the tethered cord surgery first? In what case would that happen?
Well, so first of all, maybe that's not fair to say, and a lot of neurosurgeons might disagree with that. But of all the other interventions, the tethered cord surgery might be the way to start. How can I say it? Everything what we do is delicate, but compared to a fusion or compared to a Chiari decompression, the release of the phylum is probably the least, the surgery that is least invasive in terms of like, not invasive, I mean, what we do is invasive, but invasive in terms of like what we do to the spine itself, because usually we go in between, you know, like the spinous processes and do a little opening and get rid of that connection of the phylum to the cord. A fusion or Chiari decompression is certainly a more like invasive and like complex surgery, let's say this. So you could argue that let's try that to see whether that alleviates the rest of the spinal cord pathology. But we don't have any evidence that tethered cord is really taking care of the skull base problems. Now what I see, it goes both ways. Some people have aggravation of craniocervical instability or Chiari symptoms after tethered cord release. Some people do improve. So I think for now we don't have any good evidence to say that tethered cord should always come first if you have enough reason to believe that's the case. So I like to say, like in people that have sufficient clinical symptoms in the legs with progression to substantiate a tethered cord syndrome, I would certainly recommend to do the release of the phylum before any other intervention needs to be done. So as a pediatric surgeon, we like to work up things from the bottom first and then go to the top. And here I might just be a pediatric neurosurgeon enough to think that this is the first way to go, but you have to have evidence that there's a tethered cord syndrome. If not, it's not substantiated enough.
Mm-hmm. I'm going to ask a kind of weird question. So does tethered cord syndrome, is it possible for it to cause like dysautonomia, like autonomic dysfunctions? I know. But not only dysautonomia, like tachycardia and breathlessness, but also cognitive symptoms. And have you seen surgery for tethered cord syndrome improve those things, or is that something that again is kind of wound up with chronic pain in a way? That, what would you say?
Well, certainly, you know, Dr. Henderson would say that tethered cord can cause dysautonomia based on, you know, if we think of not, so I'd like to get away to think of tethered cord being like a pull and stretch. It's just a bad shock absorbing factor if the phylum, you know, like disturbs the locomotion of the spine, and that certainly could also disturb the movement of the spinal cord at the base of the skull. So that can cause dysautonomia because the lower brainstem is like at that area. So I do see that with tethered cord release, people have improvement in this autonomic function, like with heart palpitation, chest pain, even like POTS related symptoms, and then also chest pain. So the answer is yes, I see the improvement, and it's not only with like the element of like abnormal spinal cord or brainstem motion at the base of the skull based on bad locomotion of the spinal cord with a bad phylum. It's also the fact that some people have, we shouldn't be forgetting that some people have syringomyelia with the tethered cord, and this also causes certainly like abnormal function of the spinal cord that can cause a dysregulation of the autonomic nervous system, as well as sympathetic and parasympathetic neuronal regulation. So the answer is yes, it must be, there must be a connection. Cognition, as we know from Chiari, you know, there's still, so how much of the cognitive element is based on chronic pain and other chronic elements of the disease, and that how that affects the cognition. We are studying this. I see that people feel better in the focusing and processing, but I think it's that we can we have no evidence right now. I'm
Right.
not confident to make that statement.
Right. We just don't know why.
Yeah.
Sort of to the syringomyelia thing, does tethered cord syndrome present with syringomyelia and or spina bifida? And when you see a case like that, how do you approach it for treatment?
Can you rephrase the question a little bit? So, like,
So if you see a patient that has syringomyelia and a tethered cord, or tethered cord and spina bifida, does that affect how you approach that patient surgically?
Sure. I mean, first of all, again, whatever tethered cord you have, like spina bifida, lipoma, fatty phylum, negative, like MRI, it's again the syndrome that that dictates what you decide. So, like as I said, like bladder function, leg pain, leg symptoms, and not only objective symptoms, but also how people subjectively describe their problems. And there's some uniqueness to it. You hear the same story again and again, and so that's how I see the truth. Like how people perceive their pain and what, based on their description, qualifies also to the cord problem based on the description of the symptoms. But to make it short, the syndrome, the symptoms dictate what you do, no matter what the MRI shows. Do you need to approach it differently? Yes, of course. The surgical intervention is differently. With spina bifida, you sometimes see more like adhesions. You sometimes see a split cord malformations. So basically, the surgical technique might be different. You might need to do more tethering than just cutting the phylum. You might need to address the split cord malformation. You might need to address like more elements of tethering. So that's why you always have to do a full spine and brain MRI to rule out hydrocephalus or other like webbings around the syrinx. For example, if you have a significant syrinx, of course, you have to assume it's from tethered cord or from Chiari, but some people have a significant syrinx because there's some webbing or spinal fluid obstruction in the spinal canal. There might be like adhesions and arachnoid cyst, and it's not the first time that you have everything in one person. You have a Chiari, you have an arachnoid cyst or a web at the level of the syrinx, you have a low-lying conus and maybe a tethered cord. So there are people that need to that have like all of this because they're kind of all connected, and sometimes obstruction of spinal fluid flow, even the spinal canal, is a problem. So you really have to scrutinize an entire spine MRI, if that makes sense. So basically, always, be very thorough in the workup of the spine and the spinal canal and the spinal fluid motion in the spinal canal, particularly with the syrinx.
Absolutely. So there's actually a really good question. I don't know the answer to it. Where did it go? Oh my goodness. Prone MRIs. What are your thoughts on prone MRI for tethered cord diagnosis? Could a radiographically negative tether on a supine MRI lying down maybe be visible when you lie prone? Is that something that we know yet?
No, we don't know yet. Prone MRI. So where I think prone MRIs are a viable option, if you want to show evidence whether the cauda equina, like the nerves after a surgery, are attached to the dura due to a scarring. But in the naive, assessment of tethered cord or occult tethered cord, I think we have to study that. The reason why I'm guarded, the reason why I'm why I'm concerned that this might not be the final study that we have to do is because the conus and the phylum and the nerves are moving with the spinal fluid pulsations. So the MRI is not catching this constant movement of the spinal cord with the spinal fluid pulsations. And that is not different in the supine versus the prone position. So I just think that that's where the prone MRI is also going to fail, because it doesn't correct for all the movements that's going on in our spinal cord, particularly at the distant point, where the conus is wiggling, like with every heartbeat, with every respiratory pulsation. MRI is not catching that. That's where the occult component comes in, and there's no difference in prone versus supine.
Doesn't really solve that problem, unfortunately. This has come up a couple of times from the submitted questions and in the chat. After a tethered cord surgery, if perhaps this is a patient that you didn't know was hypermobile or had EDS or something like that, is it possible to create an instability of the spine, either in the lumbar, the thoracic, or the cervical areas? Is that something that could happen after tethered release?
So if you don't know about the hypermobility, yeah, so first of all, doing a lot. So there are two answers to that question. Doing like a lot of tethered cord surgeries in people with known hypermobility, with the lumbar approach, like just doing a minimal bony removal, basically using the natural like space between the spinous processes, I have not seen that you create a significant instability. You have to do it facet sparing, meaning you don't go wide and you don't affect the facets. So that I have not seen, thanks God. So the answer is like creating an instability with the lumbar approach for tethered cord, no. Causing craniocervical instability, that is something that's a different animal. So you can, of course, say if you release the spinal cord, could that aggravate your pre-existing craniocervical instability based on the nature of the beast? Okay. Right. So that doesn't, so the question is not really like, should you know about instability or about hypermobile EDS or not? Certainly you should know, but it's more for the fact that if you have a known hypermobile EDS, the likelihood that you also have a tethered cord syndrome is higher than if you don't have it. But you shouldn't be creating an instability with a tethered cord surgery regardless.
Okay. There was a question sort of to that is there a certain percentage of postoperative patients that had occult tethered cord, so it's not on the MRI? Is there a percentage of those patients that would develop some craniocervical instability symptoms after surgery, or is that something that's just not systematically studied yet?
It's not systematically studied, but I have, it certainly could be that a certain percentage, so it's not studied, period. Yeah. It would be good to study that. But I do see, so from like looking at the patients that I was able to take care of, I would say 1 in 10 has aggravation of craniocervical symptoms. Could it be that the tethered cord had like unleashed that based on the fact that we're changing like the dynamics of the spinal cord motion? Could be. It's certainly a concern, but I want to be honest and upfront that this is a true concern. That's why we have to study it.
Yeah. So does constipation,
let me just say, I don't think it's a major problem, because I would say we would know by now. But if now patients ask me, what should I do first? Should I do my craniocervical, should I address my craniocervical symptoms, or should I address my tethered cord symptoms? It can go both ways. If the tethered cord symptoms are most prevalent and progress to a point where the person cannot function anymore, for the inability of like controlling the leg function or a lot of pain in the back, then of course it's reasonable to do the tethered cord first. But we have to understand that it's kind of all connected. It's all like dura, meninges, ligaments, and it's not a surprise that surgery can affect, like things in a negative way. We have to live with that fact. But we have to study what are the predictors of things going wrong after one surgery versus the other, particularly in people with connective tissue disorders, as we all know how this is a complex situation.
Mhm. Have you noticed that constipation reverses usually after surgery, and is it any more likely to get better if that constipation, the bowel pain, and if a patient's enema dependent, for instance, like how if the symptoms are very, very bad, are they more or less likely to get better after surgery? And if they're mild, are they more or less likely to get better? Did that make sense?
Yes, that makes sense. So first of all, if the constipation or even bowel incontinence is associated with bladder symptoms, let's say you have a bladder study that shows some element of neurogenic bladder and you also have constipation, then the likelihood that this constipation is associated with tethered cord is higher. So what I'm saying is that bladder and bowel together indicate that this is tethered cord, and the prognosis of the bowel symptoms also getting better with tethered cord surgery is better in combination with bladder symptoms. Bowel symptoms in isolation, it's hard to say. Even if nothing else is found, so both in kids and adults, I have to say, if bowel is the only symptom, and the major problem, without like a predominant bladder symptom, the chances of it getting better is like 50-50 at the most. I don't know why that is. I just today had a very candid conversation with one of patients that I saw at my clinic, where I said, you know, it might just be that even if it's tethered cord, it might just be that that's where the damage happens first, even before the bladder damage occurs. Who knows? But it's the bowel symptoms and tethered cord, it's a little bit discouraging, I have to say. And that's not just occult tethered cord. We see that in people with radiographic positive tethered cord in the same way.
So someone's just asking for a clarifier about the prone MRI. There are a few studies that show prone MRI with respiratory compensation settings can sometimes identify the phylum staying posterior despite the cauda equina settling anteriorly, thus indicating a taut phylum. Is that, I don't know what you would say to that.
I have to ask the question back. Is it a published study? And then I'd like to, you know,
read it.
Yeah.
I'll find it for you.
So I have to admit that I'm not aware of that. Let me just give a thought. That's something that we really have to study, and I always said in our meetings, Caitlin, if you know, and Dorothy knows, I really like to look at the prone MRI and scrutinize it a little bit better in people that are symptomatic and not symptomatic, or even in controls. But I'm just worried that they might not be 100% accurate either, because it might maybe isolate a phylum in the heat of the moment where you do the MRI, but then you might not catch it in others. So I would not dismiss a person having it and say, oh, your prone MRI is negative, so now you don't have tethered cord. So it's probably not like a study that is specific enough to exclude a person from a potential surgery if the symptoms are telling.
Yeah. I want to ask a question about this, because this is really odd. I've never actually heard this question before. Do you have, and this is now talking all conditions, not just tethered cord, do your patients ever report multiple chemical sensitivities? So do you see any relationship with certain neurosurgical diagnoses with chemical sensitivity? So stuff like CSF leak, mast cell activation syndrome, stuff like that. Is there some association there? Between
like symptoms and, can you say it again? Sorry.
No, so what I think they mean by this, I'm not sure if they're on the call right now, but maybe overly sensitive to scents. So if you're wearing a perfume, maybe you can't handle the smell and or it irritates your skin, or just other chemicals like maybe bleach especially really bothers you. Like I'm guessing a little bit on what they meant by that, but I'm assuming it has something to do with like sensitivities to specific chemical formulas. um, and its association with mast cell or Chiari, stuff like that.
Well, I would say, well, it's kind of like a little bit beyond my scope. What I learned, taking care of patients with known mast cell disorder, yes, of course, there is a lot of like sensitivity to suture material, to perfume, scents, but and also adhesives. That is a big problem with the mast cells. But how like mast cells are like relating to all the neurological issues, we don't know yet. As you know, with our histopathological studies, we see the mast cells in the phylum, and sometimes in patients with significant mast cell activation syndrome, we see more mast cells in the phylum. But that speaks to the fact that mast cells might invade the central nervous system and trigger some inflammatory responses and maybe aggravate the neurological condition. But how that relates to the other conditions that are associated with the mast cells, the more like skin and other organ conditions with mast cell disorder, we don't know. But mast cells are like invade everything, and we have to assume that this is connected. But I don't know how neurological mast cell sequelae tie to like dermatological or like olfactory mast cell sequelae. We don't know. But I might not be the one to answer that question.
Yeah, I'm trying really hard to get all the questions here. Is there a correlation or more of a tendency for tethered cord between tethered cord syndrome and spina bifida occulta? So what's that connection there?
Oh, with spina bifida occulta. So there's a lot of confusion about like what is spina bifida occulta. So in the in the mind of a radiologist, if you do an X-ray of the spine and you see that one of the lamina hasn't fused, so you have the defect of a spinal fusion, that is spina bifida occulta. If you see that, certainly there's a higher likelihood, up to 80%, that the phylum is not normal, because if you don't fuse your spine, that already indicates that the process of the embryonic tail has gone wrong. So it's a positive indicator. So if you have radiographic evidence of a non-fused lamina, which is the classical description of spina bifida occulta, there's a high likelihood that you have an abnormal phylum. But in the overall, sense, spina bifida occulta is basically, like not really seeing the tethered cord necessarily on the MRI. So I'm not sure I'm getting the second part of the question, but spina bifida occulta is classically like a radiological diagnosis of like non-fused spinal canal.
Mm-hmm. Well, I think you
mentioned. That is high likelihood. So basically, if you do like an X-ray and you see that the lamina are not fused, or you have like a dystrophic lamina, then that is a plus on the checklist of tethered cord and
right.
Potential tethered cord syndrome.
Yeah. Okay. So that you did answer it. There's a interesting question.
Sorry. Okay, we're fine. Yeah.
Okay. Mm-hmm. All right. Okay, so this patient has epidural lipomatosis, which I have never heard of before, so I'm gonna really rely on you here. Their mother had surgery for it as well prior when she was older. This patient also has like hypermobility and dysautonomia issues like POTS and stuff. Also has tethered cord symptoms. I guess her question though is epidural lipomatosis associated with tethered cord? And she's really just trying to figure out what to do next. Should she be seeing a epidural lipomatosis specialist or an EDS or tethered cord specialist first, with all of that going?
Yeah. So with the epidural lipomatosis, probably a tethered cord specialist first, because it can be connected to like a tethered cord syndrome. But also, I would say in generally probably like a spine specialist, because epidural lipomatosis can also be associated with constriction of the spinal canal, like spinal stenosis. Because if the epidural fat is just like significant enough, it can just constrict the spinal thecal sac and cause like spinal stenosis, not from a bony stenosis or degenerative stenosis, but from the fat like crushing the nerves, for the lack of better terms. So then sometimes you have to release that, you know, like almost do like a spinal stenosis surgery for that. So I would, so forgive me for that, but I think an epidural lipomatosis specialist must be a spine surgeon that specializes in this kind of conditions. How this is tying to EDS, I don't know, and I would say that's not the first. So you, a spine surgeon that specializes in epidural lipomatosis would be a good person, or a tethered cord. But I see a lot of kids with epidural lipomatosis. I'm sure that that patient knows that epidural lipomatosis is also correlating to the body mass index. So there might be an element of like weight loss, physical therapy, because surgery here is usually the last resort.
Yeah, there's actually a question that came up in regard to does obesity increase like the morbidity of Chiari and syringomyelia? And I think your answer would be yeah, yes.
Yes, it's as we know, like increased body mass index, first of all, raises, you know, like the chances of developing idiopathic hypertension, which is connected to Chiari and tethered cord, but also in general, an increased body mass index affects the the venous outflow, not only from the cranium, giving the increased body mass, but also from the spine. People always forget that our venous drainage is not just at the base of the skull where we have our jugular veins. There's a lot of venous drainage in that, like minute venous complex in the spinal canal. So on every rootlet of the nerves and every nerve exit, there's also venous drainage, not only spinal fluid drainage. And if you have an increased body mass, you obstruct that venous drainage as well, and by that way you increase the pressure. So all of that is definitely tied to the body mass index.
There's really interesting questions, and I think you've mentioned it before on one of these, about the impact of hormones, so maybe cyclic hormonal issues in women, or one person actually brought up a particular type of medication that affects like basically their endocrine system. Do you notice that hormonal shifts can worsen symptoms, or and I don't know, and I assume this is in the context of tethered cord, but I think it would really apply to anything. But can you speak to that at all?
Yeah, I mean, certainly, so two things. First of all, experience or empirical observation. We know that particularly women with multiple pregnancies or in like menopause or like puberty develop symptoms to tethered cord, not only with a cold, but also with lipomas. Lipomatous structures can grow with hormonal changes. So we do always see that after substantiated or significant hormonal changes or like episodes, symptoms can occur. It must be So if it comes to women, it's probably that a lot of our cells, not only like brain cells or but also like meninges and fat, they have like estrogen receptors and also other hormonal receptors, which are part of the cell cycle and how a cell works. So that might just cause like changes in this fluid dynamics, in the fluid turnover, even at the like blood-brain barrier, where blood flow and spinal fluid circulation is controlled. So that might be affected by hormonal changes, because we just have so many hormone receptors in every single cell in our body. So that's not a surprise. So that's just how we see, like the hormones affecting pressure and fluid balance. So the physiological component is that, yes, we have a lot of hormone receptors at our cell barriers, but also we see that women are affected in hormonal cycles. Why do we not observe it in men as much? I think that is more like a sociological phenomenon where men and women deal with these things differently, if I can say it.
Yeah, no, it's true. I don't know how involved you get into endocrinology, because I get very lost, but is there any way that pressure could affect the production of prolactin?
Oh, sure. That
Okay.
is pretty much, that's known from hydrocephalus.
Oh, okay.
It can affect the prolactin is produced at the stalk of the hypothalamus, and where the hypothalamus connects to the pituitary gland. And we know like precocious puberty in people with hydrocephalus, and it's not just hydrocephalus, we can also relate that to idiopathic hypertension. So that is pretty well established, so that's an easy thing.
Oh, that's good.
Yeah, so like empty sella and as I said, hydrocephalus can both cause infertility problems or precocious puberty. So that's all the pituitary gland being related to sorry about that. We need to finish up soon, Caitlin.
Yeah. I have two questions.
Yeah, sure. But hope that answers that, and that's very well established.
Okay, so really quickly, what are some of the things that patients can do to prevent the progression of tethered cord symptoms? So if they're not going to have surgery, if they don't think their symptoms are so terrible that they can't go on without surgery, how do they kind of stymie symptom progression?
So I think here the physical therapists are the ones that can help. It's a manual therapy where, with like working on the ligaments that are connected to the dura, you hopefully can help with like alleviating nerve tension and fluid pressure. So physical therapy, and certainly pain therapy. If it's mainly pain, back pain, leg pain, you see a pain specialist who can try to alleviate your symptoms. So I'm saying physical therapy and pain management. And with the pain management, you stay physically active as much as you can. But other than that, there isn't any much things out there. There aren't many things out there to help with that.
Okay, I'm gonna make this last one easy, I hope. So there are a lot of patients on tonight, especially with tethered cord syndrome, so I'm really glad they joined in. But a lot of people have been asking just us generally, how can people get in touch with you? I know the regulations are a little bit lessened right now because of COVID and everything. If people wanted a second opinion to come to your system, if maybe they even need to speak to a pain management specialist that maybe works within your system, how can they get in touch with you? And are you seeing patients for secondary opinions right now?
I'm definitely seeing patients for secondary opinions. What is a little bit hard to, I know I get some requests per email as well, being like very busy on demand in the hospital and certainly seeing patients. I usually encourage patients to get to my office, and usually my staff, like tells me that there's a request. email request I would send to my staff to have them review it. So the best thing is getting in touch with me through my office. It's not really that I have a pain specialist that I work with. I wish I would have like a better connection. I mean, we have Dr. Chopra here in Rhode Island, which is certainly a blessing. But I don't have like in the hospital like a pain specialist that would help in the preoperative selection. So to answer that question, the best way is to send a letter or like get in touch with my staff and provide as much material as possible, like any MRIs or any studies that have been done, and then my staff will help me, to review it, and then I can facilitate the appointment. And I'm happy to share, my office number. Also, emailing my staff, Donna or Kim, which are my secretaries, will help. They just forward the email to me, and then we can decide how we can prioritize the assessment. I'm very happy to give second opinions and see patients.
Awesome. All right, I know your phone is blowing up, so I'm going to let you go.
I'm so sorry. I wish I didn't, I had to take call. It was unexpected, but I didn't want to miss that opportunity to be available and answer as much as I can. And Caitlin, if people need my contact and also the emails of my office and numbers, just email me, and you are happy to share that with anyone who wants to be getting in contact. But emailing to my staff is the best option.
Excellent. Thank you so much, Petra. Have an excellent evening. Thanks everyone for joining us.
Thank you.
Thanks everyone.
All right. Well, good being in touch, and we can continue this. I'm very happy to be available.